Okay, good morning, everyone. It's time to get started. Can everybody hear me okay? Yeah, okay. So everybody, this is Dr. Amy Shoptaw. She is going to introduce our guest speaker this morning, and I've asked Dr. Shoptaw to talk a little bit about her role at Phoenix Children's, because just out of curiosity, how many of you know who she is and what she does? Okay, 3. Okay. Okay.
Okay. Good morning. Thank you, everybody, for attending today on the Grand Rounds. My name is Amy Shoptaw. I'm a pediatrician, had a clinical practice in the community for 25 years, now work with Phoenix Children's, and the medical director of the Center for Resiliency and Wellbeing here at Phoenix Children's, which actually sees patients or children and families who have gone through significant childhood adversity, and also educate the community about what childhood adversity is, as well as how important it is for relational health. I'm honored to be able to introduce the speaker today. Presentation is Trauma-Informed Care That's Possible, Practical, and Productive. I heard Dr. Forkey present about 5 years ago, and she made such an impression on me that I actually closed my pediatric practice and started the Center for Resiliency and Wellbeing here about 4 years ago. Heather Forkey is a professor of pediatrics at the University of Massachusetts Chan Medical Center and vice chair of pediatrics and director of the Foster Children's Evaluation Services of UMass Memorial Children's Medical Center. She serves as the pediatric director of Lifeline for kids at University of Massachusetts Medical School. Dr. Forkey has been recipient of local and federal grants, large grants, to address issues of children in foster care and to translate promising practices to address physical and mental health needs of children who have been traumatized. She's published and presents nationally and internationally on the topics and serves in leadership roles at the National Child Traumatic Stress Network and Massachusetts chapter, local chapter, and the National American Academy of Pediatrics on issues related to foster care, mental health, and child trauma. She co-authored this book, which I highly recommend. It's an excellent book for anybody going in pediatrics in any subspecialty to help you with helping with kids that have gone through any type of adversity. Dr. Forkey continues to inspire me in the area of compassionate care for children and families, and I know she will do the same for you. Without further ado, Dr. Forkey, the camera's on you.
Amy, thanks so much. You guys I'm so lucky to have Dr. Shoptaw with you there in Arizona. I'm incredibly jealous. And I am also incredibly delighted to be with you today. Indeed, we're going to talk about trauma-informed care, and hopefully we're going to try to make this something that feels very practical, like you can make a difference. I just need to disclose that I do get some book royalties from the book that Amy just showed you. Today, we're going to get to some learning objectives, hopefully to implement some engagement strategies that set the stage for trauma-informed care and create safety in the pediatric hospital or outpatient setting. I'm going to choose some surveillance and screening strategies that you can easily implement. And when you do so, you'll be able to have some direction for yourselves and for your families. And then think about some techniques that you can use in the office or the hospital setting right away. But I also want to say, to get real, like what are we really going to do? What I really want for you guys to leave with is an understanding of what's the difference between trauma-informed care and what you do now. Can you actually do anything that helps or changes outcomes? And do you actually have the time to do any of this? I will say that trauma-informed care is a term that's really become quite a buzzword. People are talking about it all the time. I get asked about it in all sorts of circumstances, but it's really kind of vague to most people. And I will say that the SAMHSA did us no favors when they tried to explain what it was, because their diagram, while having incredibly important principles in it, particularly around safety and this trustworthiness, it's still pretty abstract. And I will say the other issue related to trauma is that many of you may have your understanding of trauma-informed care growing out of your understanding of the Adverse Childhood Experiences study. And for those of you who may not have heard of it, this was a study done in 1998 which surveyed 17,000 adults with Kaiser Permanente health insurance, asking them about ultimately 10 things that they may have experienced in childhood, mostly related to abuse and household dysfunction, like substance misuse by a caregiver, incarceration of a caregiver, divorce. And it gave every one of those adults a score between 1 and 10. And it was remarkable at the time because it identified the fact that most adults have had bad things happen to them. Only a third of the people surveyed didn't have bad things happen to them in childhood. And 1 in 8 people had 4 or more of those bad things happen. But it was even more remarkable because they were able to look at the health outcomes of these adults, and they found that they had, as in this graphic, some pretty significant impacts on injury, mental health, maternal health, infectious disease, chronic disease, risky behaviors, and opportunities. But those were adults. And so for those of us who practice pediatrics, does this have any relevance? And in fact, we in pediatrics didn't really pay this study much mind, except in the intervening years, we've really come to understand that many of the diagnoses that we do deal with all the time, every day, particularly related to development and mental health or behavioral health, have a significant impact from or direct correlation to early significant relational trauma. And so we can't ignore it because trauma is what we're actually dealing with all the time. And I think for us to really understand what our role is, we have to start by understanding the stress response and why we see what we see, right? So you have all gone through medical school. You understand that we have stress responses as humans. There's the freeze response where you just stay still, hoping that the threat or predator doesn't notice you and passes you by. It's not all that effective for humans because we're very large and we get noticed. Then we have fight or flight, which may be more effective. We can run away or we can fight the danger or the predator. But again, humans don't have claws. They can't hide underwater. If you're a child or you're pregnant, you can't fight or flee very effectively. So humans actually had to evolve to have other stress responses, which would be more effective for us. These are good for the creatures that can benefit from these most effectively. But humans' best asset turns out to be our brains and each other. And so we evolved to develop a stress response called the affiliate response. It's also called tend and befriend. And what it means is that under threat, what humans do preferentially is look to other humans and say, hey, will you help me with this stressor? If you think about your own daily life, if something comes up for you in the clinic or in the hospital, you're most likely not to run away from it, not to just stand still, but to turn to the other folks around you and say, hey, I've got this issue. Can you help me deal with it? In fact, that's what our patients are doing when they come to us. But as it turns out, this is an oxytocin-mediated response. And oxytocin is critical because, not because it helps us to deal with the threat, but because it improves what's called our social salience, meaning we get better at looking at whether the people we're turning to will actually help us or not, right? Because if you think about how this happened, that we evolved to have the stress response, as cave people, once we developed overhand throw and wanted to hunt in groups, we needed to turn to others to say, hey, can you help us deal with this? But I had to recognize, did that other cave person want the same predator, want the same cave, or were they trying to access the same resources, and were they going to kill me if I tried to get their help? And a mistake, if I misread that, could be deadly. And so it turns out that the people who were not good at recognizing the people who were going to help them or not help them were culled out of the gene pool. And what we find is that we're really very good as humans at recognizing whether the people we turn to are safe and positive for us to use, and we develop then some pro-social thoughts and actions to facilitate that support. And we have adaptive stress responses. But if we turn to other humans and they cannot or will not help us, now we've got two problems, right? We have the original problem, and we have these people we've turned to who want the same thing or are hostile toward us. And now we have to develop some antisocial or defensive thoughts to protect ourselves and some distress responses. And so what we see is that we lose this capacity for the affiliate, which is actually usually the most useful, and we get shoved really over to fight or flight, and as our primary response. And when we think about the pediatric patients that we care for, who are constantly in circumstances where they've turned to others and they cannot get that support, or the caregivers around them will not give them that support, they get this overwhelming reusing of the fight or flight response. And when that happens, we have this overstimulation of the HPA axis, this over promotion and overproduction of cortisol, which certainly impacts body systems in general, but has profound effects on the immune system. After all, the body thinks that the stressor is a predator coming at us. So it turns up the inflammatory response. It actually turns down the ability to fight infection. It alters which genes are turned on and turned off at the epigenome, making it so that more and more cortisol gets pumped out again and again. We sort of flood the developing brain and body with this cortisol. And a developing brain and body flooded with cortisol is going to have impacts on brain connectivity, immune function, as I mentioned, and this epigenetics, which genes are turned on, which genes are turned off. And that is a whole lecture in and of itself, but let's sort of give just the shorthand is that we make adaptations which are useful to us in the short term to deal with the threat, but they ultimately have long-term health consequences. And that's what the adverse childhood experience study showed, but it's also what we need to understand in pediatrics. And I will say that what we see most commonly in pediatrics are these brain and autonomic nervous system changes because they impact development, emotional regulation, and mental health. We can see impacts on the immune system, on the gastrointestinal system, on the cardiovascular system, but a lot of those impacts are more long-term and things that are more commonly seen in adulthood. For us, we are really seeing a lot of those behavioral health and developmental consequences. And really, this begins to explain why these events or these traumas are associated with health consequences. But it's not the events alone, right? It's not the stressors by themselves. It's whether or not there were other humans to help you manage that stress, that support or lack of support, which either allowed you to use affiliate or forced you to use fight or flight predominantly. Which is why when we talk about stress as either positive, tolerable, or toxic, we're not describing the stressors. We're pointing out that this is an alteration of our stress response, which either gets buffered by supportive relationships, making the stress tolerable, or it isn't buffered. There's not sufficient protective relationships, and our responses, our physiology becomes toxic to ourselves. This becomes critical work for us in pediatrics then, because development and relational health, the ability to form and support those relationships, those are our sweet spots. That is what we do all the time. And so if any medical providers need to understand trauma-informed care, we do. And so I think what we want to do is break down and think about what are the principles of trauma-informed care informed by this science that we've just talked about. And it requires now 3 frame shifts. If you understand that science, you begin to ask the question, first of all, it's not what's wrong with you, but what we're seeing in terms of health, developmental, and behavioral consequences relate more to what happened to you. So I need to ask a different question. And yet, ironically, as I pointed out before, it's not about summing that suffering, coming up with a number of bad things that happened to you as they did in the adverse childhood experience study. But it's about building the buffering. It's about creating those opportunities to support kids and allow them to have those supportive relationships so that stressors are not toxic, but more tolerable or even positive. And ultimately, what this says is that recognizing and treating the effects of trauma is my job. It's not the job of my mental health colleagues alone. It's not the job of only adult providers. It's my job as a pediatrician. And so when we think about what trauma-informed care is, there's primary prevention, there's secondary response, and there's tertiary treatment. And they come from that shift in our framework. That primary prevention is about building buffering. In every interaction we have with kids and families, we need to build buffering. We need to build it in our relationships, and we need to help kids and families create those safe relationships in their own settings. We have to have a secondary response, asking not what's wrong with our patients, but what happened to them. So if we hear about traumas, we want to ask about symptoms. If we hear about symptoms, we want to ask about traumas. And then we need to recognize it and treat it. So let's think about a case as a way to sort of put this frame shift into practice. And I'm going to tell you about a young boy, a 13-year-old boy named Scooter, who presented to our emergency room actually at the beginning of the school year last year. Scooter was in his classroom and he had pulled out a bag of Doritos and he was eating the Doritos even though it was class time. And his teacher told him he needed to put the Doritos away. And Scooter said, nope, I'm not putting the Doritos away. And so the teacher said, you know what, Scooter, it's not time for Doritos, you got to put them away. Scooter didn't do that. And so the teacher came over and he took the bag of Doritos away from Scooter. At which point, Scooter went from 0 to 60. He lost control and he tore apart the classroom. He threatened other children. He destroyed the classroom, so much so that the class had to be evacuated. The support staff from the school had to come in and work to have him calm down. And he was then transported to our health facility. And so if we think about what the approach to Scooter might be once he showed up in our emergency room, we would do SOAP, right? We would start with some subjective information from the patient and potentially his family in their own words about what was going on. We'd get some objective data, do an exam, get some labs. If it was appropriate, we might do imaging or screening. We'd then put these pieces together in an assessment and we'd come up with a plan. But what I'm going to suggest to you is that when we use SOAP, we're going to get this particular information. Scooter reports that he got angry when the teacher took his Doritos and he acted out because the teacher wouldn't let him eat. He is denying suicidality or self-harm and he's got nothing else to say to you. He is not talking to you. And so if we're going to think about what else we're going to do, SOAP only gets us so far. And we're far more effective with SOAP if we also use water. So here's our new acronym. I love acronyms. Dr. Shoptaw will tell you I'm a little acronym slap happy, but I would like you to consider using SOAP while you're using water. And water stands for wondering together or engaging with the patient, asking about trauma and symptoms, beginning to treat in your office, clinical, or hospital setting, always using empathy, and making referrals if needed. Again, this is not unique to trauma-informed care. In fact, a lot of this, like SOAP, is exactly what you do for all other issues as well. So if we're thinking about our frame shift, the first thing we always want to do is build that buffering. Think about how we are promoting that buffering for our patient. And we do this best by what's called engagement or wondering together with the patient and family. You know, I mentioned to you that the stress response is always looking to see, is this a safe social context or is this an unsafe social context? And we do that because we have this process of neuroception. Neuroception is the term for the fact that you're always scanning every circumstance for danger. Even when you don't think you are, you are. So you're listening to me give this lecture, but if there were a loud noise or a funny smell or lightning flashing in the room, you would certainly be distracted and you would be immediately paying attention to what was going on. And we're constantly scanning the environment for danger, and that information is being shunted to our lower brain so that first and foremost, we keep ourselves safe. In healthcare settings, there's constantly a lot of information coming at our patients, which promotes a lack of safety, right? There are sounds, which are sounds of safety, and there's sounds that are sounds of danger. Low-pitched sounds are sounds of danger. If I sing for you the Jaws theme, doo 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 doo, I don't have to explain to you that that's a movie about something scary, because low-pitched sounds are sounds of danger. So that when we are in a hospital setting, all of our machines that are running are making a hum that is in that low register, already putting people's nerves on edge. So when we talk with our families, we want to make sure that our vocal tone is sort of high-pitched and musical. If you think about how a kindergarten teacher might talk to her students, she says, okay, boys and girls, let's get going. She uses high-pitched musical sounds so that they are, because that is the automatic understanding of safety. You do it too, I'm sure, when you walk in and see a child who's frightened. There's also body language of safety. As soon as I cross my arms, I'm projecting a lack of safety and a lack of openness. So we need to make sure that our sounds, our body language, even our facial expressions are promoting openness and safety. We also have to do it with how we look at the perspective of the patient's mind in mind. I want to think about this situation from their perspective, where I'm thinking about how were they thinking about it, not how are they describing it to me, not how I would think about it, but I'm going to look at it with their mind in mind and wonder with them, with curiosity and acceptance, respect, and empathy. And I know a lot of you guys are like, oh, for the love of God, you know, like I don't need to come to a grand rounds to learn these principles because that's sort of why I went into pediatrics. 100%, totally agree with you. But we don't always bring it into every opportunity to meet with families. We don't sort of share power or form this therapeutic relationship, sort of saying, you know what, I know something about medicine, but you know everything about your situation, your family, your culture, your community. And so let's think about this together. What's your understanding of what's going on here so that we can come together and come to a solution and question together? Because when we do that with curiosity and acceptance and respect and empathy, we're really starting trauma-informed caring, which is going to allow us to use that first principle and build that buffering. When we do that with Scooter and we sort of sit back and say, hey, Scooter, wow, this sounds like a really rough morning. I am just curious. Tell me a little bit more about what was going on that morning and what with your teacher and maybe what happened before, what happened after. And we find out that he was angry that the teacher took the Doritos, so mad because he had no right to take them. They were not his. And before that, he had done some math testing. It was the beginning of the year and he hates math. He's always gotten bad grades in math. It did happen in the late morning before lunch. He was hungry. He's also, we find out, new to the school and he doesn't know many other kids. And so we're getting some pretty important information that allows us to understand more about the situation. He's pointing out that the teacher whom I had assumed was a female was a male. He feels that this teacher has no right to take he feels threatened by these being taken from him. He also was just completing math testing, which is something that makes him feel inadequate and he feels anxious about it. He was also hungry. So we had sort of a physiologic issue and he had sort of another issue relating to his feeling of lack of safety is that he's new to the school and he doesn't know many kids. So just by opening up and asking some other questions, we get a much better perspective of what was going around this issue. Okay, I'm on a time crunch. I have to see this patient, so I'm going to go to my objective. And I get my vitals, they're normal. I see that he is obese. He's calm in his affect now. His hand hurts, it's swollen. We don't really need to do any labs. Maybe we would do a TIC screen. We could x-ray that hand and we find that he does have a boxer's fracture. But what else do I need to do if I'm really thinking about not what's wrong with him, but what happened to him? I want to find out more about whether she's telling me that there's some traumas here. He's moved to a new school. He doesn't like math. There's been this big event. And I need to ask more about, were there other traumas or are there other symptoms? And so I'm going to do this via surveillance and screening tools. I have to ask when I add my water into my soap. Surveillance is a process we use in pediatrics all the time. Surveillance are those open-ended questions. What brings you here today? What hurts? How long has this been bothering you? In trauma, we have some open-ended questions as well. They are, has anything bad, scary, upsetting happened recently or since we last met? If we're doing primary care, we can do this with families all the time. What was your experience, parent, of being parented? Do you want to parent your child the same way? And one question, when people say to me, what's the one question you think is the most useful? Has anyone come or gone from the household lately? And if we use these questions with Scooter, we find out that his stepdad left last weekend after his mom and his stepdad had a fight. Doesn't want to talk about it, but he did hear the fight and it wasn't any different than the ones they've had in the past. He doesn't know why his stepdad left. So again, now you have some more information that there may be some domestic violence, there may be some other traumas going on for Scooter. And so you're going to need some more information because recognizing and treating the effects of trauma is your job. It's not just what's wrong with him, it's what happened to him, and I need to figure out what that is. I will point out that here's where we use screening. And when we use screening, we're screening for exposure as well as symptoms. I want to go off on one brief tangent because there is a lot of ways and a lot of people talk about doing just ACE screening or using the same questions that were used in the Adverse Childhood Experiences study and using those tools clinically. And I think come to think of the line from Princess Bride, you keep using that word, I do not think it means what you think it means. For those of you who have not seen Princess Bride, you got to go watch that movie and you'll understand where this quote comes from. But when people use the term ACE screening, they're using that inappropriately. The ACE questionnaire was developed for a research study. It was intended to be used in populations to look at population effects. It does not have validity in populations. These are questions about history, but those are limited specific history. It has no predictive value. It has no specificity. And if you do not ask about symptoms and you just ask about a specific limited number of things that may have happened to someone, you're not really guiding yourself into managing and treating that trauma. There are also people who have suggested that when people take the ACE questionnaire, and I can't say screening tool, they are assigned a number. This is how many bad things happen to you. And people can get feeling like, don't assign me a number. I'm not a number. It also disrupts trust in the relationship with the healthcare provider. It makes people feel unsafe at times if it is not addressed in an appropriate way. And so it may undermine your ability to promote that affiliate response, to build that buffering. And so it begs the question, okay, if I'm not supposed just to ask about what happened, but also what are the symptoms, what symptoms am I looking for? What am I supposed to find out about? And I will say, I think we in pediatrics have a bit of a gap in our understanding. When I trained, I learned an awful lot about anxiety, depression, ADHD, but no one really ever taught me about what traumatic events lead to in terms of consequences and diagnoses. And it turns out that, again, from my mnemonic loving brain, there's really three main diagnoses that we're looking for. Prolonged grief disorder relates to the death of a person to whom someone is close or intimate, and you can kind of get this preoccupation and intense pain. There's adjustment disorder, which is a maladaptive reaction to an identifiable stressors that are usually day-to-day stressors or regular life event stressors, not things that are particularly extraordinary, but it can lead to extraordinary symptoms of worry or distressing thoughts or rumination, can lead to anxiety, can even lead to suicidality, but it's related to identifiable stressors that are pretty common to life events. In contrast, the third trauma diagnosis is post-traumatic stress disorder. These are threats that put you at risk to your own life or the lives of someone you love. And it results in these intrusive avoidance or hyperarousal symptoms. Now, I'm sure you've all heard about these three diagnoses, but I think in pediatrics, we haven't taken it upon ourselves to include them in our day-to-day differential. And yet, if we're going to take trauma on, we really need to be thinking about these diagnoses as well. I'm being a little disingenuous. There is actually one more diagnosis you need to consider, and that is complex post-traumatic stress disorder or developmental trauma disorder. For our patients who've had repeated and severe interpersonal victimization without support and disruptive of the caregiving bond with their primary caregiver, we can see a trauma response that goes beyond post-traumatic stress disorder. And what this also requires of us is an understanding of why that caregiving relationship piece is so critical in everything we do. When Dr. Shoptaw introduced herself, she talked about the fact that she does relational healthcare. Why are the relationships that kids have, those primary relationships, so critical? And they are so critical because they shape who we are and how we understand ourselves in the world. And the primary relationship are those attachment relationships that we have. And yet attachment doesn't always go smoothly. You know, most of our kids have caregivers that provide them with that sense of security so that the child can go off and explore the world. But many of our kids are in situations where the caregiver cannot or does not provide that sense of safety and security, which allows the child to explore the world and begin to understand the world and themselves. If a caregiver has some responsiveness, but it's limited, sometimes they're available and sometimes they're not, the child really has two choices, right? They can try harder, they can try to get the attention and they cry for it, and they get intrusive with the caregiver. And that's called ambivalent attachment. Or they can give up and they can say, you know what, I'm not gonna get that help from my caregiver, I'm not gonna seek it. And that's an avoidant attachment. When kids are living with an abusive relationship, we get what's called disorganized attachment. There, the caregiver isn't either there or not there, but when they turn to the caregiver, they can become hurt. And so not only do they try to seek the comfort, but they don't get it, but they also get injured in the process. So it's really 4 attachment types, and they can result in kids having different types of attachment security. So there's the kids who have caregivers who are consistently available to them, and that's a secure attachment. Those kids have their own positive relationships. They feel they can be explorers, they can be curious because they know that they can go back and forth, and that caregiver will protect them and be there for them if they get into trouble. They can persistently problem solve because they know that they've got that secure relationship behind them. For kids whose caregivers are not consistently there and they keep seeking that, but they can't ever get it, these kids are very anxious and they can be passively helpless. They're very dependent kids. They have real trouble in novel situations because they can't rely on someone to be there for them. Kids who have an avoidant attachment, have given up on their caregiver, are the most isolated. They're often hostile. They're the kids who are the most disliked because they push other people away. And then kids who've experienced disorganized attachment or abuse are often very emotionally dysregulated, and they can be overly controlling or they can be overly caregiving with people, but in an artificial way. Attachment discussions take much longer, and I'm just giving you a taste of them, but attachment becomes so critical because attachment forms the internal working models of ourselves and the world. When a baby cries and the caregiver to whom the child is securely attached says, "Oh, baby, you're hungry," that baby learns this feeling is hunger, and there's people who help me solve that, and there's a solution, and I can communicate that solution. And when they have a caregiver who doesn't attend to them or says, "Oh, you are so damn greedy, why do you keep screaming?" that baby learns something very different. It learns that this feeling is being greedy, and there's no way to solve that problem, and the world is overwhelming, and there's no way to communicate that. Our stable understandings of ourselves and the world come through those relationships that we have with others. And so it becomes really critical for us to understand that some of our kids have not only experienced traumatic events, but they have done so in the context of supportive relationships that are absent or missing. And so what we see in those kids is a misunderstanding of their own bodies. They often have pain symptoms or they disassociate from their own body. They can't process information or control themselves or soothe themselves. And so they're incredibly dysregulated in all sorts of circumstances. And they don't understand themselves. They have a sense of loathing. I am no good. I am that greedy baby. I am the baby who can't manage the world. And they don't understand how to interact with others. And so developmental trauma disorder or complex post-traumatic stress disorder adds on these layers of symptoms, which we need to begin to understand, both in their type and their severity. So when kids experience traumas, we can see some kids who just have a mild disruption of sleep or toileting or eating. Some of our kids can go on to have not just those functional difficulties, but symptoms of either grief or adjustment disorder or post-traumatic stress disorder. And kids who have the most severe traumas and the least support may go on to have not just functional difficulties, not just post-traumatic stress disorder, but this developmental trauma disorder with affect dysregulation, this negative self-concept, and interpersonal disturbances. And so we as pediatricians really need to begin to wrap our head around what is this other area of mental health that we need to understand, and how do we discriminate it from the ones we're good at, right? Because trauma diagnoses do overlap with anxiety and ADHD and depression. And there have been a number of studies recently pointing out that we as pediatricians often underdiagnose post-traumatic stress disorder and misidentify our kids as having either depression or anxiety or ADHD. And what matters there is that we then put them on the wrong course of treatment and wrong course of care if we don't identify what the trauma diagnosis is as well. So what you need to understand is that there's some tools that help you to do that. There are a number of screeners available to you for post-traumatic stress disorder and other trauma disorders. Here is one, and I'm just going to show you one that's very useful. I have the link to it. It was created by our colleagues at Intermountain Health. And what we found is that it's there's a parent version for younger kids. There's an older kid version that they complete themselves. It's really easy to score. You can see mild, moderate, and severe symptoms with just looking at it. You don't have to calculate out a number or score. You can just glance at it and you begin to see whether the symptoms are mild, moderate, or severe. It asks and groups post-traumatic symptoms in terms of sleep, hypervigilance or intrusive symptoms, and avoidance symptoms. And most critically, it adds a suicidality question from the PHQ-9. And what we know is that kids who experience trauma are much more likely to experience suicidal ideation and, in fact, to complete suicide. There are additional tools, ones that you're familiar with and probably have already started using in your practice. And we can use some in infancy and early childhood, some in later childhood and adolescence. And I'll direct you to the lowest row, which points out that what you may need to do is to look at, are these ADHD symptoms? Are these anxiety symptoms? Are these depression symptoms? Or am I seeing trauma symptoms, and using these screening tools to sort of discriminate what symptoms you're seeing? I will point out that kids can have symptoms that are related to physical health consequences. Scooter has obesity. Is that related to his trauma? We are hoping that soon we will have biomarkers, but we're not clinically there yet. And so I'm putting on your radar to keep checking the literature. Here is probably the most recent paper that kind of identifies what's probably on the horizon. But unfortunately, as of yet, we can't yet identify whether some of our physical health outcomes or consequences are trauma related. But if I go back to my SOAP and I add in this screening tool, what I find out from Scooter is that he really is demonstrating some pretty severe symptoms. And when I ask about his exposure, which is a part of this screening tool, we find out that his dad, his real dad, died due to an overdose when he was 9. That stepfather, who recently left the home, has beaten him up in the past. In fact, he was even in foster care briefly last year. And he's moved recently with his mom. And what he's showing you here is that he has symptoms in almost all the domains of post-traumatic stress disorder. And in particular, you'll see that he has a lot of trouble with reminders. He's got a lot of trouble with his sleep. And he's got a lot of trouble where he's trying not to think about what's gone on for him in the past. He's not suicidal. So again, let's go back to our SOAP. If I hadn't done all this, I would have diagnosed him as overreacting to a situation. Maybe he's got some impulse control and anger management issues. I probably would have considered DMDD, oppositional defiant disorder, maybe anxiety or depression with irritable mood. And I would have said, you know what, we need to get psych in here and possibly put him on a mood stabilizer. But if I'm doing trauma-informed care, I need to think about always building that buffering and recognizing that treating trauma starts with me. Treating trauma starts with me. And so I need to use that last part of my water to begin to do that process. How can I begin to treat Scooter, he's in our emergency room, he's in sort of a deep end of trauma, but there's still things that I can do here. I need to use empathy, and in truth, I'm probably going to need to make a referral, as I often do for patients who have illnesses that go beyond my limited scope as a generalist pediatrician. When we treat trauma, we have to start by saying, hey, you've got some stuff going on that's related to some pretty bad things that happened to you. And I'm sorry those have happened to you. And it's pretty terrible what you've been through. But I'm here and we're going to start working on this together. We need to reaffiliate. You need to stop and not just rush to what you're going to do. You need to start that sense of safety and affiliation with your patient. For Scooter, we're going to discuss the fact that what happened at school was probably related to some of the things that have happened in his past, and that when he was hungry and had just had to take that math test, and then this male teacher took away something that was his, it impacted his sense of safety, his sense of self, and his ability to respond was sort of limited because he had gone into his lower brain, and he was kind of reminded of some pretty terrible and scary things that had happened for him. The American Academy of Pediatrics has some great tools to start the process of treating. The 3 R's stand for reassuring, returning to routine, and regulating. When we identify that a child has experienced trauma, we want to start by saying to them, you're safe now. We want the family to show the child they're safe now, they're safe now, they're safe now. Scooter's mom needs to respond to him and let him know that even though his stepdad left and even though they've been having trouble, he's safe with her. We need to let him know that he's safe in this hospital setting. We need to say it with words, with high fives. His mom can do it with hugs. We can do it with weighted blankets. We can do it in a household with a tent or a place for kids to go sort of be so they can feel safe and secure. Getting kids back to routines is a critical part of this. Routines are how we manage our lives and shut down the stress of every day. They tell kids that there's things that are expected and going to happen. The beginning of the school year, there's no routines. And so they are dysregulating for almost all kids. And it's not a shock to me that Scooter came in at the beginning of the school year when there was not the routines built in yet into his day. And so we need to start to establish routines in the hospital setting. He'll need them started back in the school setting. And for our kids, they can establish those routines at home with cues. Hey, this is what we do at bedtime. This is what we do at mealtime, even with charts at the school or at home. And then the third R is to begin to regulate. We start that by relaxing, by shutting down the stress response, belly breathing, stretching, relaxation techniques. And then we do it by helping kids to begin to name their emotions and understand what they're feeling. When we talk with Scooter, we do this by talking about the cognitive triangle, or in Scooter's case, the cognitive Dorito. You know, kids often believe that they feel what they feel, and they don't know why they feel what they feel. And they just act the way they act. And they're not always sure why they act the way they act. But it turns out that what we think impacts what we feel. And what we feel impacts our behavior. Scooter didn't act out and tear apart the classroom out of nowhere. Supposedly, it was because his teacher took away his Doritos. But he actually had a number of thoughts that led up to that. He had some thoughts about himself after he took the math test. That I'm stupid and everybody else can tell that I don't know what's going on, until he was embarrassed. And he had a sense of being overwhelmed because he couldn't manage this work. So those thoughts about the math test set up a set of feelings. And it was those feelings of inadequacy and shame that led to his behavior. He acted out, he acted in a dysregulated way, but they didn't come from nowhere. We can also point out to kids that they have control over their thoughts. They can change what they're thinking. When they take a math test and they don't do well, they can say, I'm stupid, or they can say to themselves, hey, I haven't learned this yet, but there are people here who can help me. And that will change my feeling to one of optimism or seeking support. And that can change their behavior. So we can work with kids on understanding how thoughts and feelings lead to behaviors, and that they have control over those thoughts and feelings. Ultimately, Scooter's not going to have his problem solved just by what we can do in the emergency room, or even if he's admitted to our inpatient setting. He's going to need to get to some evidence-based trauma therapy. And we have a number of these in most communities. There's child-parent psychotherapy and parent-child interaction therapy, which are for youngest kids. There are therapies to try to prevent the onset of post-traumatic stress disorder after a bad event. That's CFTSI. There's really great therapies to help kids who already developed trauma reactions. One is eye movement desensitization and reprocessing, or trauma-focused cognitive behavioral therapy. And for the kids who have the most significant traumas, like complex PTSD or developmental trauma disorder, we can think about attachment regulation and competency. Some of our kids will also need developmental supports, and families will need things like community resources, like housing support and food supports. But we are used to making referrals. I don't handle kids with surgical urgent issues myself. I send them to the surgeon. When kids have a cancer diagnosis, I refer them to the oncologist. Making referrals is part of what we do. But I also explain to families what they're going to find when they go to those referrals. And so we need to talk to families about what's going to happen when they go to these trauma-informed treatments. And so I have here for you sort of some principles of trauma-informed care. And it starts by building those relationships that we do with that wonder and talking about normal responses to trauma. It helps building in that parent support, that affiliate support. And then it helps kids to begin to express and regulate the feelings that they have, manage the anxiety, and begin to do that cognitive triangle, reprocessing and reframing what's happened so it ceases its ability to harm them. You know, many of you will say, hey, look, I don't know what I'm supposed to refer these kids for. And the bottom line, if there's been a recent trauma, you can usually intervene yourselves with the 3 R's or cognitive triangle or promoting play and follow them. If kids are already having trauma symptoms and they're young kids, you might want to refer to something like parent-child interactive therapy, teaching the parent how to respond. Older kids may need behavioral therapies like dialectical behavioral therapy. If there's truly diagnosed post-traumatic stress disorder, you're going to want to get them to an exposure-based trauma treatment like TFCBT or EMDR. And when you see multiple domains impacted or developmental trauma disorder, you're going to want to get them to a TFCBT provider who's comfortable with complex trauma or one of the complex trauma treatments like ARC. Quickly, I want to point out that there's not a lot of evidence for medication in treating trauma, but that's not meaning none. You should never use benzodiazepines. You should never use second-generation antipsychotics. But there is evidence for our kids who are having the sleep impacts of trauma to using some melatonin to help them to get back onto a normal sleep cycle. And for kids who are having nightmares, prazosin is got good evidence to help deal with the nightmares that are related to trauma. For kids who have anxiety and depression in the context of PTSD, you can consider an SSRI. Specifically, sertraline is the one that's been associated with benefiting kids who have this independent anxiety or depression symptoms associated with trauma. And then if we see kids who have these increased reactivity or ADHD, we always want to start with the evidence-based trauma therapy and reevaluate. But for those kids, instead of using stimulants for ADHD, we want to consider alpha-2 agonists. Again, each one of these could be a whole talk in and of itself, but you want to have a plan in your head. You're thinking, kids are tricky. This could be a lot of things. Trauma seems pretty complex to me, Forkey. Treatment takes time, and those medications, oh, they're scary. But what we're telling families is, you know what? Sometimes it's hard to know what exactly we're dealing with, and it's going to take some time, but we know that trauma treatment works, and we're going to start that first and monitor. We're going to add some skills. We're going to do that ourselves with our 3 R's, with our cognitive triangle. And if I absolutely have to move to treating something first, I'm always going to start with treating sleep. And so when I use that process with Scooter, I change my assessment. It's not what I would have done if I hadn't used the full WATER acronym. I think what's going on for him is PTSD and maybe developmental trauma disorder, that he was triggered to have some terror reaction in the school situation. We're going to discuss with him why he's having those symptoms. We're going to implement the 3 R's and discuss the cognitive triangle. We're going to think about prazosin because he identified the fact that he's having pretty severe nightmares when we did the PTSD screening. And I'm going to refer him for TFCBT or ARC. When we take care of kids and we're thinking about it with a trauma lens, we're doing 3 things. We're doing primary prevention all the time, every kid, every family. We're not just summing the suffering, we're building that buffering. We're not just asking kids what's wrong with them, but if we're asking them what happened to them, if we hear about trauma, we're thinking symptoms, and if we hear about symptoms, we ask about traumas. And if I get pushed in that direction, I recognize that it's my job to go further. I want to point out that not every case is as complicated as Scooter's. You might have a 4-month visit, right? Austin they come in for a 4-month visit with Austin. If I did this with my regular soap without water, I might find that he's eating and sleeping well. He's starting to sleep for an extended period at night. Everything looks great. He's a well 4-month-old, and I'm just going to do my vaccines, start talking about when we're going to introduce food, and we're going to talk about making sure that he's on his back when he does go to sleep. But in every instance, I want to add water. And if I open that conversation up a little bit more with some curiosity and connecting with that mom, I find out that she's actually worried that it might not be safe to leave him overnight. She's anxious for him. And as I explore that a little bit more, asking about traumas, I find out that both moms grew up with great parent examples, but one mom's worried that she's not doing this as well as her mom did. I can use some maternal depression screening, and in this case, it's negative. But mom wonders, should she feel this exhausted? I am going to call it out. I'm going to say, hey, I am so appreciative that you've come and brought this to me. We may be starting to see some beginnings of depression, but you are doing a great job with this baby. It is so hard to feel this way and so hard to parent when you feel that way, using our empathy. And then I might need to refer her, but I'm going to start by referring back to myself, bring her back. And if I'm still seeing these symptoms, or now she's screening positive for depression, I'm going to get her back to the caregivers who can handle that from here. I don't have to handle everything myself. I have others who can help me. Similarly, you might have a sleep complaint. This is a patient who came in for an asthma exacerbation, but while they're there, they report that he's having trouble falling and staying asleep, predating starting that albuterol. You notice that his tonsils are big and he's got some wheezing, but you talk about bedtime routine and maybe even add in some melatonin. You say, call me back if it doesn't get better. But how much time would you save if you said, hey, tell me more about this? When did it start? What's going on with this? And how is that affecting your family? And we find that this sleep issue is overwhelming. Everyone's exhausted. If we ask a little bit more, has anyone come or gone from the household lately? We find the grandmother who had previously been doing his bedtime routine had a stroke one night. She's now in a nursing home, but the ambulance came and he witnessed the whole thing. When we screen him, the caregivers point out that he's having sleep symptoms and maybe some intrusive symptoms. We can say, hey, we think something might be going on here. This could be some grief. This could be post-traumatic stress disorder, but it's not been long enough for us to make that diagnosis. So let's start with the 3 R's. Reassure him that he's safe. Begin to get back to those bedtime routines that have been lost by the chaos, and do some things to regulate, some deep belly breathing. Play can be incredibly regulating for our kids. We need to bring that empathy in. Wow, you and your family have been going through and managing so much. We're so glad you brought it up here. And then refer back to yourself. Come back in 3 weeks. And if it's still not getting better, consider referring for evidence-based therapy for that trauma. So did we achieve our objectives today in the time that I had? Let's see. We said we'd start off with some engagement strategies. So I said we can include some open-ended questions, validating concerns, using a vocal tone, which is musical and higher pitched, and open body language. We came up with some surveillance and screening strategies about who has come and gone from the household, or whether there've been any recent trauma. We talked about how important it is to add screening for some of the most important trauma diagnoses, such as post-traumatic stress disorder, adjustment disorder, grief, and developmental trauma disorder. And we need to think about our attachments in our patients. Then, are there things that we can do? We can discuss the 3 R's. We can talk about the cognitive triangle. We can even talk about play as an incredible way to reestablish affiliate supports. Sometimes we'll need to make referrals to evidence-based treatments. Occasionally, we need to even use medication, but those are all available to us to really take trauma on and manage it for our patients. Okay, did we do what I really wanted to accomplish? What's the difference between trauma-informed care and what you do now? You want to switch from asking what's wrong with you to what happened to you. And ironically, not just some what happened to it, but build that buffering, recognizing that for you, understanding trauma and treating its effects is part of our job as pediatricians. Can you do that? You can if you add water with your soap. And do you have time to do it? Well, I'm wondering if you don't have time not to, because we're going to misidentify things if we don't do this. But I also have a song, and I think if you just remember the song, that'll be pretty quick. So many of you are younger than me, and you may not remember Safety Dance, but if you go back to the 80s music, this is a fabulous song which you can apply to our patients who've experienced trauma. You can wonder if you want to. Engage with mind. There's trauma care. They know you're there. Oxytocin is on your side. You can see if you want to, but you can do. The screen alone studies that won't help you know what to do. I know, it's pretty silly, but I still have more. We can treat if you want to. They are here, and so am I. To affiliate first, of course, or first, but you need to say my. Want to in the folks will do as well. Try the 3 R's for the therapy for enough of my thing. That what you really want to do is shift your framework and really begin to incorporate trauma-informed care into each and every interaction you have with kids and families. Okay, that was a lot of information in a pretty short period of time. I'm impressed that some of you have hung around, and so if you have a question or two, I think I have maybe 4 minutes to answer those questions.
Thank you, Dr. Forkey. It was wonderful as always. I take many pointers away, and I know that was a lot of information, but hopefully you guys got some stuff as well. I loved the idea of treating trauma starts with me. I think that's extremely important. And I think I'd even bring in the concept of trauma as not just being trauma of abuse, neglect, but even a medical trauma or a significant childhood adversity. And I think that's really important to understand that trauma can equate to adversity as well. And it's important to think that every one of you will come across children that have experienced adversity. We know it's very prominent. And the new study in Arizona was about 47% of children 0 to 17 have experienced at least one adverse childhood experience. And so you will come across that no matter what specialty you're in. Any questions here from any of you that are here live?
There is a question in the Q&A about second-generation antipsychotics, because I flippantly said, don't use them. There actually is no evidence base for the use of second-generation antipsychotics in the treatment of trauma. There are certainly kids, especially kids in foster care or in certain circumstances, who have been placed on second-generation antipsychotics. And I think the question there is, what is their diagnosis? If kids are being given second-generation antipsychotics really just to sedate, then they may have been prescribed inappropriately. There are kids that we encounter who have diagnoses that go beyond trauma. But I would point out that many of our kids, especially our kids who are in the foster care system, have been given diagnoses because developmental trauma disorder was not considered. They haven't been given the opportunity to have evidence-based trauma therapy. And the effects that we're seeing from the second-generation antipsychotics are, in many instances, sort of the sedation effects. It's certainly more complex than that, but this is also where referral comes in. For those of us in pediatrics, many of us are pretty uncomfortable with second-generation antipsychotics, and getting our psychiatry colleagues involved with these patients to help us tease apart the kids who've had the most significant pharmacology treatment in the past is a really important piece of this. And the reason why in water referral is there is because you don't have to do this alone. I mean, I would never do neurosurgery, but that doesn't mean that I don't handle kids who wind up with neurosurgical consequences. I don't take tonsils out myself, but I still see kids who have obstructive sleep apnea. And so I think recognizing that we have a role to play and that there's a place where we can be an advocate for these kids, getting them to the right referral so that they can get these things treated appropriately.
Thank you. Anybody have any questions here? I have one more for you. I know you went over, trauma-informed care and all. Why is it important that all pediatric clinicians understand not just childhood adversity, but the importance of relational well, not just primary care physicians, because I know that was some of the cases, but also if any of you go into any specialty within pediatrics, emergency room, GI, neurology, and many of the others.
So as you pointed out, Dr. Shabta, medical consequences that kids have themselves can be traumatic. So every specialist may encounter a child who's had a medical trauma and needs to be aware of it from that perspective. But we as pediatricians, especially for our kids who have chronic illness, are helping to build our kids not just and treat the one diagnosis, but we're looking to build a healthy, resilient child. Understanding how trauma impacts kids and what we can do to promote a child to manage the stressors of their illness or the other stressors in their lives is a piece of pediatrics. Whether you're a pulmonologist, an oncologist, a nephrologist, your kids are all going to come to you experiencing stressors related to their diagnosis or related to their life. Understanding how you can promote helping those kids to build the buffers in their lives, how you can help their caregivers to buffer these kids through the experiences that they have, and always asking yourself, not just what is the diagnosis, but why? Why do I see this diagnosis? and asking yourself, do I have another role beyond just treating the underlying condition? Do I need to think about the traumas that these kids are experiencing and address those as well, so that I can have this kid and family be the healthiest they can possibly be?
Thank you. Anybody else? Yes.
Is there any idea of policy from either the AEP or Congress right now to incentivize practices outside of like academic centers or big institutions to have like a counselor in the clinic? Like, is there any way that we can provide financial incentive to a community pediatrician and say you should have a counselor or psychologist 2 to 3 times per week, so that we don't have to, you know, we have a kid who has a lot of trauma, they need counseling, they need therapy, you have to go somewhere else, call back your Medicaid card. It'd be easy for us to just say, hey, there's somebody here you can talk to tomorrow, today.
Dr. Forkey, did you hear that?
Sorry, I couldn't hear it. No.
So the question is there any policy within the AAP or anything out there now that's trying to get the within the medical home into an office of a psychologist, counselor, therapist to kind of help the pediatrician? Did I capture all that?
Yeah, like kind of like a standardized thing. Like
A standardized thing.
have something, but you know, like somewhere rural or somewhere in the community don't have the resources that we do here. I feel like it should be a standard of practice because this is affecting almost half of children in Arizona.
So a standard of practice of having inside the medical home or in a clinic, a therapist, counselor, somebody who can help the pediatrician when these adversities and trauma come up.
So yes, the American Academy of Pediatrics is working very hard on promoting integrated care, which is what you're talking about, sort of that integration of mind and body in our healthcare settings. I will say, so they've created a whole social council on healthy mental and social development, that they've created a working group who's working on addressing these issues, and in particular, integrated care is one of the issues. I will say that as we've gone through the mental health crisis over the past few years, there have been changes to many states' Medicaid rules and federally qualified health center rules, which allow for more integration of mental health and for policies for paying for integrated mental health in creative ways. In Massachusetts, and I'm not sure about Arizona, you can have 6 visits with a mental health provider that are covered even without a diagnosis. So while you're still trying to figure out, is this a adjustment disorder, is this PTSD, we can get kids to a mental health provider to start working to address the symptoms that we're seeing. And that's covered by Medicaid in the state of Massachusetts. Other states have implemented that as well, and I'm not sure about Arizona. But what you're seeing is sort of this rolling across the country of a greater understanding at the federal level and filtering down to the state level to improve the reimbursement for behavioral health for children in particular, and to improve the opportunities to integrate it within the medical home or primary care setting.
Wonderful. Thank you once again, Dr. Forkey, as always. It's just a pleasure of mine, and thank you all for attending this.
Thanks, everybody.